Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is Anterior and Posterior Case Presentation, Enough Pearls to Make a Necklace, our synchronous virtual course with our speaker, Dr. Greg Caldwell, who's a graduate of the Pennsylvania College of Optometry, where he also completed a one-year residency at the Eye Institute in Philadelphia. He's a fellow of the American Academy of Optometry, a diplomat of the American Board of Optometry, and a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutritional Society. He works as a disease consultant in private practice, where he has done a number of FDA clinical trials. He has lectured extensively throughout the country and internationally. In 2010, he served as a president of the Pennsylvania Optometric Association and has served on the AOA Board of Trustees from 2013 to 2016. In 2023, he was named one of the top eye doctors in America by Newsweek magazine. So with it, please, a nice welcome to Dr. Greg Caldwell, my partner, who's going to edutain us for the evening. Greg, take it away.
I appreciate it, Joe. Thanks for the nice introduction. And like I said, this is going to be a team effort here as we get in here. But let's be COPE compliant and CE broker compliant and disclose that I have lectured from Alcon to Dompe and been an advisory board from Dompe to the Optometric Advisory Visionary Team, received honorariums for these services. I do sit as a non-salaried financial affiliation with Pharmanex and New Skin Healthcare Registries, a chairman of Diabetes and Macular Degeneration Advisory. That's an outcome-based registry. Here's the two, or really a few important things here. And as you guys figured out, there are ladies out there too, that we were co-owner here of Optometric Education Consultants. But anything that's mentioned in here is independently prepared by me. No one's really trying to pay me to try and change anyone's opinions out there. And the content of this course is presented without commercial bias. I'm claiming no superiority. I'll be mentioning products tonight and showing instruments. No superiority that's out there. Most important, again, everything has been mitigated by the regulatory bodies. So with that said, we're going to start off real quick here with a polling question. So the polling question is, a patient presents with a central retinal artery occlusion. It happened today. What would you do? Refer for an anterior segment paracentesis? Have a patient breathe into a brown paper bag, not red, not blue, not green, but brown paper bag. Order or refer for stat blood workup for giant cell arteritis. Refer the patient to the emergency room with a note saying they had a stroke in their eye or a stroke-ready hospital. What would you do here? Let's see. Do I have the polling question open?
You do.
Like I do. Yep. And it looks like it's rolling in. So what
people go to the icon that says polls on the right, and it'll come up for you.
All right. What would you do? A patient has a CREO, central retinal artery occlusion. It happened today, not 3 months ago, but today. Refer for an anterior chamber paracentesis. Have the patient breathe into a brown paper bag. Order refer for stat blood work for GCA. Refer to a stroke-ready hospital, the emergency room. All right. I think we've given us enough. Let's display it. And we see here we have 3% paracentesis. We have breathe into a brown paper bag. We have send for stat blood work for GCA and refer to a stroke-ready hospital. Okay, good. This number's changing. Joe and I have been talking about this here for a while. I would give two answers here. I could say maybe order for stat blood work. I could give partial credit for that. We don't know the patient's age, but we do have a central retinal artery occlusion. We do want to send this patient to a stroke-ready hospital. And let's just talk about a case of a 65-year-old man who reports sudden loss of vision in his right eye, count fingers at 2 feet. And we have a 20/25 in the other eye, a grade 4 relative afferent pupillary defect, and let's take a look at the photos. So here we are, and we have a nice clear left eye here. Over here we can see, what I always like pointing out is the largest cotton wool spot that you're ever going to see. And this is probably, say, maybe later in the day, maybe a day later, because when they first happen, you really don't get this type of swelling. It kind of maybe looks like the left eye over here. It takes time for that edema to show up. So, this here is, probably, even though it feels that it happened today, maybe a day or two old, maybe covered that eye, noticed it, and came in. But either way, it's relatively fresh. It's within the week. And we have a central retinal artery occlusion happening to this eye. Now, back in the day, what would be the treatment? What would be the follow-up? We were taught anterior chamber paracentesis if it's less than 24 hours, or push on the eye, to try and maybe move that embolus that could be there. Do some stat blood workup, especially if they were 50 or older. This could be giant cell arteritis. We would do SED rates, C-reactive proteins. We would do a complete blood count. And then we would monitor this patient, say, every 3 to 4 weeks for that kind of neovascular type of glaucoma for this patient. Now, that all kind of has gone out the door. Joe has introduced me to Nancy Newman, Valerie Buis. They're down in Emory. They were the ones that kind of pioneered this. They kind of did the retro look back and kind of came out with a protocol, quite a few years back. Maybe it was like 2016-ish, 2017, where we want to send these patients, and it's this category here, the TIA, or amaurosis fugax, the branch artery occlusion, the central retinal artery occlusion. I'm going to revisit it here in a slide or two down the road. Not the vein occlusions, but the artery occlusions. We want to send them to a stroke-ready hospital. And a stroke-ready hospital is certified and recognized hospital, meets standards to support how to treat and work up these patients kind of in an efficient manner. It was in collaboration with the Joint Commission that's out there focusing on stroke. Now, I'm not going to read that whole list to you. Just know that there is a qualification process just to become an acute stroke-ready hospital. Now, here's the reason. Because what happens is 20% of the stroke or heart attack were in the 20% of them were within 3 years. However, those who had the CRAO, BRAO, or transient ischemic attack, 80% were within 24 to 48 hours. So of these people that have a central retinal artery occlusion, branch retinal artery occlusion, TIA, 20% of them ended up with this stroke within 3 years. However, 80% of those were within that 24 to 48 hours, and those remaining 50% were there in 2 weeks, and then the majority within the next 90 days. So that's why, in a sense, we just don't send for GCA workup. We basically, we want to identify in those who are on this. I'm going to close the question. I see I didn't close it, so sorry. So those are on this. And as a reminder for those who are already new, maybe Google or look or research the hospitals in your area to see which ones are the acute stroke-ready hospitals. So when this walks in, pretty easy. Just had one the other day. Patient walked in, CRAO, within a week. Explained to them, I said, sorry, I just made your day really bad. My day became really easy. I used to have to do some workup, follow you, do some different things. Now I'm just going to send you over because there's this 80% within 24 to 48 hours of a stroke or a heart attack. We don't call the primary care doc, or you can, but you're not sending it to the primary care doc. You're not sending it to the retinologist. You're just a really, really easy referral to the stroke-ready hospital. So the acute stroke-ready hospital, it's a basic stroke hospital. It's better than not being certified. These were created in 2015. However, there are, above the acute stroke ready hospital, there's the primary stroke center, thrombectomy capable stroke center, and the comprehensive stroke center. They keep getting better and better and more comprehensive in a sense as you go down that list. There are certifications that are out there, again, that between the American Heart Association, the American Stroke Association, this joint commission, everyone's working together to really, time is critical. And I believe it was the American Heart Association, I think Joe speaks to this, that classifies a central retinal artery occlusion, branch retinal artery occlusion, or TIA, of a stroke of the eye. Which one was that, Joe? Was that the, I know you speak of it, so.
Well, actually, I was involved helping with a white paper, editing it for a collaborative group, and that it was being adopted by the American Heart Association. They didn't talk about branch or TIA in this this new white paper. They talked extensively about central retinal artery occlusion. They call it stroke. They don't call it stroke of the eye. They don't call it risk factor for stroke. A true CRAO, according to the American Heart Association, is now a stroke.
There you go. So not even a stroke of the eye, just a stroke. The eye is an extension of the brain, so a stroke. So there we go. So what I've done here is I just kind of showed you, I just Googled this, it was a couple of years ago. I just said, stroke-ready hospitals in Pennsylvania by county. And you can see here's Allegheny. Now, I practice in Blair County, so I have the UPMC Altoona, which is great. It's that step above that acute, so it's a primary stroke center. So I know exactly what I'm going to do when these happen. So I just told you I had one the other day that happened. I said to the patient, look, my day is easy because I used to have to do this workup. I now know what to do with you pretty efficiently. We're going to get you over to the Altoona Hospital, but send them over and make a phone call. Talk to a triage nurse, talk to someone that's over there and say, look, I'm sending you someone over that has a stroke. It's a stroke in their eye, but it's a stroke. And please keep an eye out for them because, as we now know, 80% within the next 24 to 48 hours could have a stroke or a heart attack. And the other hospital that is, I practice in, Blair County. And then the other hospital that's nearby is Cambria County, and it's a primary stroke center. So those are the two big hospitals in the area. And the nice thing is I know where I can send them. Depending on which side of the mountain they fall, I can get them to a stroke-ready hospital that's out there. Here's a pretty classic case. I saw this on ODs on Facebook. And this is from November 27th of 2018. And it kind of highlights what we just covered here. It says, last week I saw this patient, 80-year-old man with a central retinal artery occlusion. I sent him for that stat. That's how we were taught back in the day, blood work, and told his daughter that a carotid ultrasound should be done to avoid, to evaluate risk of stroke. Didn't make it urgent. Unfortunately, he had a stroke the very next day. So there you go. It just kind of shows you. Since then, I make a point from learning from mistakes. I did some research, and there's this nice article here basically talking about sending to a stroke-ready hospital, and which states the patient should get, with an acute CRAO, should be sent to the ER for immediate stroke eval, including MRI and the other testing. So this was the picture that this person on ODs on Facebook posted. And again, there might be some perfusion right here, but you can see the central retinal artery occlusion and maybe a little perfusion, or maybe this will swell here in the future, but this could be that cherry red spot that is starting to form.
I think,
So
Greg,
this was a,
I think in that case, it was probably a ciliary retinal artery that they had. So that's why they still have that perfusion. Now,
yeah, this
before
could
you
be
go
right here,
to,
the cilioretinal.
before you go too far, a good question came in, and this could lead to some good discussion. If patient had TIA 6 weeks ago, no other episode since then, still refer to stroke-ready hospital. Greg, I'll let you field that one first, and I'll share with you what I think.
Yeah, my cutoff is a week. Any of these things that happen within a week go to the stroke ready hospital. Once, now if it's 8 days, I hope that doesn't happen. I'm not sure which way I would fall. If it's 10 days, I'd say, okay, you're outside that window. I'm now going to make it urgent that I'm going to get you to your primary care doctor, but I'm also going to pick up the phone and discuss with the primary care doctor. Now, this one is 6 weeks out, I think was the question that you posed, Joe. So we're kind of outside that, super critical window, but I don't want to make this not an urgent situation, but it's not a referral, in my opinion, to the acute stroke ready hospital. But looking forward to hear what you could add to that.
Craig, I agree with you. And Ellen, one of the hardest things that we have to diagnose is transient vision loss, TIA, transient monocular vision loss, because unless we dilate and happen to find an emboli, we don't have anything there except the history. So we have to make very, very certain that we're dealing with somebody who has a vascular transient loss of vision and a true transient ischemic attack. Once you're sure of that, I agree with Greg. The critical period is 24 to 48 hours. Once you hit about 6 days, we're not really sure what to do. Risk is there. ER, not really what I would probably do in a situation like that. It's probably the person needs to be in the hands of a stroke neurologist. Now that can be hard to do. So sometimes that may need a coordination with the primary care physician. They may be able to wiggle a patient, smuggle a patient onto somebody's schedule easier than you can, unless you have a good relationship with a stroke neurologist. So again, I don't pull the fire alarm there either. They do need to be evaluated. But it's not as clear what happens when we're talking 6 days, 6 weeks.
Perfect. Any other questions?
At this point, there are none.
Okay. So here's another case. I think Joe presents this case. I think he saw it on ODs on Facebook, but then it eventually ended up in my office. And here is this is not what was presented on ODs on Facebook. It was just these like visual fields and so on and so forth, and was referred in for, it was a younger patient. And you can see here now, a few days later, we have this branch retinal artery occlusion. Oh, sorry, wrong patient. It's coming up here. So let me erase that. This actually was April 8th, 2020. Again, COVID times here, but this was at our office. And my colleague, because we were spreading out the time, he texted me and said, hey, what do you think? And he sent me the visual fields first. And then I wrote, okay, ischemic optic neuropathy or a branch retinal artery occlusion. Yeah, that's what I'm thinking. And then he goes, hey, I just took some pictures. I sent the Optomap. We have an instrument at our office that can manually check for an APD. And he said there was a logmar in that eye of 0.3, so a small APD over there. So after he sends me the photo, then I said, call if you can, call when you can. And basically the conversation I wanted to have with him was, look, I realize it's COVID times. It's kind of starting to get into the heart of it. It's April 8th. If you remember, the wheels came off of the bus in March. And I wanted him to be able to make sure that we sent this patient to a stroke ready hospital. So that all played out, and this was kind of cool. On a Monday, he wrote that patient with the visual field the other day, the artery occlusion. We called her today to follow up, and she had an aneurysm of the carotid artery. And then that's basically when I said that's why they go to a stroke ready hospital. You did what most people were not aware of. Congratulations. Did they coil it? I'm not sure if they coil, carotid artery aneurysms or however they manage it. And she was seeing a cardiac doc about it. So probably had some type of aneurysm. It threw a plaque. But the cool thing was we got and did exactly what we were supposed to do for this patient and get them to that, acute stroke ready hospital to get this, diagnosis of a carotid artery aneurysm. This was the patient that I was jumped ahead to. The patient reports, this was the young female that ended up at my office, patient reports vision loss. And I really like this because it was a visual field defect in a younger patient and went through this whole kind of, MS type of thing. And what was really cool is this OCT here is pretty classic. And what I'd like to point out is when they're early, you can see here, I'm kind of cutting through where the ischemia is. My point is that it becomes pretty dense. It's starting to swell. Things are dying. And you can see that that coherent light cannot make it through to that outer retina. And it's really neat if you get one, neat for us academically, not neat for the patient, that if you ever get like a central retinal artery occlusion and it's early and it still looks like this up here, it hasn't swollen, your OCT becomes your diagnostic tool because this will all start to become opaque. And then the outer retina, where those photoreceptors are, as you can see here, you can hardly see the lines, the external limiting membrane, the ellipsoid zone, you can hardly see these lines are ill-defined. It's because the signal can't get down through. So this might be an OCT, might be the way that you diagnose this, because when they come in early, I wish I could hide this part of the slide. They do look normal. Now, this is a day or two later, and if you look right here, you can see the embolus. So there's a nice big embolus right there. I'm not sure if that would be calcium or cholesterol. It's certainly not like a thrombus, but you can see the occlusion here. And this patient went to a stroke-ready hospital because oh, no, sorry, this was 14 days ago. This patient went to the stroke neurologist because it was outside that 7-day window that's out there. So I'm not sure if I have the outcome of this for this. I was looking for it earlier today, trying to remember the patient's name, and I could not find it. So here's a, branch retinal artery occlusion. Again, the greatest risk was in 48 hours. You want to get these people for an immediate referral if they're within a week, urgent workup, stroke neurologist, phone a friend, help these patients out. And then does this apply to a central retinal vein occlusion, right? So we have a central retinal vein occlusion here. We have a branch retinal vein occlusion here. Remember, these vein occlusions, the plot is around that lamina curvosa whenever it's a central retinal vein occlusion. The clot forms, here in this branch artery occlusion around. No one's, as we say, tossing the bullets. No one's tossing the cholesterol, the calcium plaque, forming a clot somewhere else in the body, and it's traveling through. So these are kind of forming at the eye location, just kind of a traffic jam, and everything just kind of backs up. So these do not need to be referred. So it's only the artery, central retinal artery, branch retinal artery, the TIAs, as Joe said, they're difficult to sometimes discern, but true transient ischemic attack are all strokes, and they need to go to stroke-ready hospital, but not vein occlusions. Joe, anything you want to wrap up or any questions before I move on to the next
No
case?
questions, but here's a question that has come up to me before, and I do have a definitive answer. And Greg, you showed a nice list in your area of all the facilities. Now, the question is, what if you don't have something like that in your immediate area, but you have something that is a bit of a site away? Well, a paper came out recently that looked at patients who bypassed a local ER that was not stroke ready to go to a stroke ready hospital. And they found out those patients actually did worse. So if you don't have a stroke ready hospital within, I don't know, 30 minutes or 40 minutes, but there is a closer ER, that will suffice. Those patients can fare well. It's just better what Greg has said. Get them to the best place you can, as long as it doesn't delay their care.
Perfect. Good points. All right, I think we've hit that one enough. Let's do this question here. Let's open it up. And it's basically a I consider keratoconus a condition of the anterior surface, a condition of the posterior surface. I never thought of it this way. So what do you think of keratoconus? Is it an anterior, like epithelium type of condition, posterior surface type of disease? Where do you fall on this one? Yeah, looks like the answers are rolling in here nicely.
And the chat is clear. We are good.
Fantastic. All right, let's see. Okay, looks like everyone's pretty much laying in. Here it looks like a nice split. We have 35%, 24 people saying, 27 now, saying it's a condition of the anterior. We've got a condition of the posterior, 43, and people just never thought of it that way. So that's good. That's why we talk about it. I'm going to give the answer real quick. I want you to think of this as a posterior type of disease. Let me make sure I close the question this time, so it's not in the way. So case 2, and this is kind of where it all started. And with the diagnostic equipment and this high, this is an old case, but now with the kind of more of the urgency or the attention, I shouldn't say urgency, but the focus now being on the diagnosis, and we have the instruments out there, we can get these patients a little bit earlier. So here's a 25-year-old man that came into my office. He saw 3 ophthalmologists and optometrists in the past year. He complains of this ghost image. So what that means is when I walked in the room, I said, just help me out. He covers his eye. He says, Doc, that big old E on the roof over there, when I cover my right eye and I look at that, I see the E, I see another E. It's kind of a ghost image. So we got a monocular type of diplopia. He's had 4 dilated exams, no diagnosis yet. Now, he's a 25-year-old man, engineering graduate now. He was a student and then he's a graduate. And so what I mean by that, because in my area, there's a lot of railroads. So when people say engineer, they're going woo-woo engineer. This guy was a mechanical engineer, likes to know how things are built and this and that, and why in one eye does he not have that ghost image, and in the other eye he has the ghost image. So he's very passionate that right eye is clear. And Doc, I want to know why. And you can see he's passionate because I'm the 5th doc that he's coming to see. So 20/20 vision, a very normal refraction here. Externals are normal. Slit lamp looks good. Fundus exam looks good. He brings me some records. He's had a topography. He's had fluorescein angiography. He's had a CAT scan and an MRI. So kind of a fun case. Where are we going to start here? So ask yourself, if you had this person come in, ghost images, thoughts of ghost images, monocular diplopia, a quick list here that I would think of is uncorrected astigmatism. Well, hopefully within me being the 5th doc that would have been found. Maybe some irregular cornea astigmatism, could be EBMD, Salzmann nodules, keratoconus, or post-refractive keratorefractive surgery, right? RK, LASIK, PRK back in the day. Maybe a flap wasn't made correctly. We got this, but there's no history of any of that. Go into the crystalline lens, kind of this oil drop cataract. Sometimes these patients can get like an index change of their nucleus versus their cortex. And then we have an epiretinal membrane, macular edema, CME, CSME. But remember, he's had a topography, fluorescein angiography, CAT scan, and MRI. So what I like to do when I do this lecture live is I like to say to the audience, now, what is the total power of the eye? And like to pause and kind of give everyone time to think. And most of the people will say 60 diopters. And I said, good, perfect. We look at Ks all day long of the cornea. So what's the average? Yeah, 40, 43, 42, 45. I hear all different answers. Okay, let's just say 40. 40 over 60, right? That's 2/3. So 66, 67% of the power of the eye, the 60 diopter eye, 40 some diopters, 67% come from the cornea. So that's why when the cornea is not happy, whether it's dry eye and that precornea tear film, Salzman nodules, SPK, a little bit of edema, it doesn't cause much cornea stuff to happen to create that vision loss when it's 67%. So I decided that's going to be where I started to look. So I have instrument. And so again, going back to the second slide of this presentation where I say, hey, you know, we're not claiming any superiority, but I will claim that there's superiority when you can look at that posterior curve of any type. I'm not picking out any type of topographer. This is an orb scan technology. There's other technologies out there. And so what we're looking at here is this axial power, kind of this anterior surface. And when I look at it, you know, it's kind of suspicious. You know, we have 45.8 and 44. You know, I can probably talk myself into something going on with that left eye, but this is where it starts to now really come into play. I like it because I can see the anterior float. And this is where that polling question came in. Is it a posterior or anterior surface disease? So I'm looking at this topography and everything's, you know, when I look at it, we got a diopter's worth of astigmatism. Yeah, we're relatively steep. Here's that keratometric map that I showed you. But when I jumped over here, and this does an optical pachymetry reading, he is 379. Now, I did have access to an ultrasound pachymeter and confirmed, you know, he was like 390, 400 in the center there. So extremely thin. And because we know that typically they're around 500, 550, you know, thank goodness for the ocular hypertensive treatment study to teach us that, you know, what the average central cornea thickness is. Now, you got to be careful with an orb scan and optical pachymetry because if there's a scar, if there's edema, it can only go as deep, but his cornea was clear, right? 4 other docs plus me looking, his cornea is clear. So why is he so thin? He didn't have LASIK, so on and so forth. And it's because, and I missed it back in the days of my PCO days, 1991 through 95, even my residency year, that keratoconus starts in that posterior float and starts to bulge forward. This is kind of stage 1, or this is a form frust keratocone, a frustrated form of keratoconus. And it's starting in the back, but it really hasn't created that classic keratoconus appearance that we see on that anterior surface because it's early. And this is how I felt when I finally realized, hey, this is a disease of the posterior surface. And that's why I asked, you know, when you think of keratoconus as an anterior surface or a posterior surface, think of it now as a posterior type of condition. So this is stage 1 in the new classification, or a frustrated form or form frust keratocone. And these are now important to diagnose, or at least diagnose and manage and follow, because if they progress, that's whenever we want to get them now to a cornea specialist or someone that's doing cornea cross-linking to be able to kind of stiffen up that cornea. And we're going to talk about that here in a second. Now, I do keep a couple RGPs, diagnostic RGPs at my practice. I keep a plano, about 44 diopter, and a plano 39 diopter. And the reason being is that with all the refractive surgeries, and back in my day, there was a railroad company, not the engineer, but the true engineer railroad, woo-woo. These guys, they paid for RK, and now they're all coming in 20 some years later. Corneal weakening procedure. They're hyperopic, and some of the incisions are tightened up, so they got some irregular astigmatism. And I use these RGPs to kind of smooth out that surface, put a numbing drop in there, and kind of recreate their surface to see if some of their symptoms go away. So that's what I did for this gentleman. I put one of those diagnostics on, did a little over refraction, and had him look through that. I think it was like a -1 when it was all said and done. And he looked through it and he goes, "Hey doc, that ghost image has gone away." Now, what that tells me is he has enough irregular astigmatism. This here, posterior float, is bulging enough. It doesn't look like that classic keratoconus, but you can see he's thin enough here to create enough irregular astigmatism, and we solved his problem. And really, has never had to go through corneal refractive or cornea cross-linking. We've been following ever since. Rock solid, stable. I don't know. Maybe he was a child. There's only one eye. Maybe it was a child. He rubbed that eye. Maybe had an injury. But this is a form thrust, and he's not interested in wearing an RGP just to get rid of that because he is right eye dominant. So we just follow him year after year. What I do want to do is just kind of show you, here's an advanced keratoconic patient. You can actually just see it just by kind of looking around looking at the patient. You can see the cone, have the patient look down. The Munson sign is whenever that eyelid takes up the shape of the cone when they look down. And then this is, an award-winning photo here. We got the bilateral Munson sign all in one shot here. So this is an advanced keratocone. And all I want to do is just kind of show you what it looks like on a topography that can actually look at that posterior float, right? So what I encouraged my office to do whenever we had when I was at one place and I moved over, I don't know how many years, 14, 15 years ago, I said, look, whenever this thing decides to get upgraded, can we go to something that has a posterior float? And it's luckily with 5 docs in the practice, it has worked out beautifully because this float here I look at all the time. But you can see this one's pretty easy here. This posterior float has bulged so much now, it's affecting the anterior. You can see this one, if you just had an anterior, you wouldn't miss this cone. But I thought it was kind of cool. Look, only 343 here. What was the other one back here? I think it was like 379. Yeah, 379. So you can see it doesn't take much. The cornea is very complex. It's not all about that, thin or thickness. It's not really that defines it. Remember, there's collagen, there's elastin. Cornea is super complex. And you can see that this right eye is an advanced keratocone. And here's the other eye that I was showing you whenever the bilateral Munson sign here with the posterior float starting to bulge forward, creating, you can see here that can't even, with that optical pachymeter, can't even get a reading in some of these areas that's out there. So ask yourself, this is not a polling question. Just ask yourself now, we just talked about and defined that this disease kind of starts in the back of the eye, the posterior cornea. What happens when that cone gets so steep, right? And it stretches, maybe the person rubs their eye and tears Descemet's membrane, and Descemet's membrane ruptures, and now what's back there is aqueous, and that pours into the cornea, right? And so that's called hydrops. And so that's why these are so painful whenever they do occur in these keratoconic patients. We don't see that often anymore. Because we have the diagnostics, we got cornea cross-linking, we got some people that don't want to be treated. And so what would happen here is this patient, we would treat them. These are tough to treat. Do you cycloplegia them? That doesn't really help too much. They are painful. I've had to use a couple patients where I reached to my opioid lecture and did some tramadol for a day or two until that cornea kind of reseals back there. That endothelial cells will pump that out, but then they usually end up with a scar. And then I usually show a cornea transplant, but for the sake of time, we're not going to show a corneal transplant. Most of these patients will have to go through a corneal transplant, maybe to get that vision back if they scar up. So keratoconus is a progressive corneal disease, focal thinning, steepening, bulging, genetic factors. This was some studies out here, statistics. 1 in 2,000. Now in the Netherlands are saying 1 in 400. I think what we are able to do is with our advanced diagnostic equipment, I think we're just picking up on it a little bit more. I'm not really sure if the prevalence has changed. Maybe it has, but I just think we have the diagnostic equipment to recognize it. And conventional management, eyeglasses, RGPs, scleral lenses do well. They do some interstromal rings to kind of flatten those cones out in areas to maybe help get rid of some of that steepness. So some of this more conventional RGPs or eyeglasses or specialty. And then corneal transplant was at the very end, but now we have cornea cross-linking. So we want to get these patients diagnosed earlier. Now, could this patient, going the wrong way. Could this patient right here go through cornea cross-linking? Not really. That horse is already outside the barn. But my 25-year-old that I've been following, if he starts to change, he would be a great patient that, great early diagnosis, follow him, show the change, get everything off to the corneal specialist, someone that does cross-linking, and maybe start that cross-linking procedure. So, I think we all know the signs for keratoconus, the astigmatism, maybe some frequent headaches, halos, ghosting. I think, just be aware, that with these cornea conditions, that cornea being 67%, that you're having some patient with those ghost images that are out there, it could be keratoconus. So cornea cross-linking, what is it? Right now, most of the procedures are done epi-off, so they remove the epithelium. They soak the cornea in Photrexa. This is a procedure that's done by Glaukos. They're going to be using Photrexa, and you do that for about 30 minutes. And basically, you're checking for flare. You're scraping off that cornea. You're super hydrating this cornea with riboflavin. And then once you see flare and you have the right cornea thickness, that cornea swells, then you basically smack it with radiation for 30 minutes, UV light. Now, Joe knows over the last few years, I've been really into antioxidants and anti-aging, taking some functional medicine courses, so on and so forth, kind of helping the patients out. This is kind of the opposite, right? This is taking an eye, in a sense, soaking it with riboflavin. I think it's one of the vitamin Bs, B3, B6, somewhere in that range. And you're soaking it and you're hitting it with ultraviolet, in a sense, for 30 minutes, aging that body, right? We know what happens when you get out in the sun. You can see I was out in the sun. You start to cross-link the skin. It helps with the wrinkles and so on and so forth. What we're doing is aging that cornea, and it stiffens it. So everything that we do with anti-aging and all this antioxidants and free radicals, we're just using that, in a sense, in the advantage here to stiffen the cornea. And that's what cornea cross-linking is. And I can tell you that I have done more and more cornea cross-linking with the right diagnostics, following them frequently, and then having a good corneal specialist. Joe, I know you work in a specialty practice. Do you do cornea cross-linking in the practice?
Yes, we do. We have corneal cross-linking, just like you said, epi-off. It's been very successful. Now, before you go on to your next case, question came up. I think it was also to the audience, not just us or you. I think Susan's maybe asking all the other people in the group. Does anyone use piggyback lenses anymore for keratoconus?
Let's see if anyone replies. I have a doctor in my area that does them. I think I've done 2 or 3 successful piggyback lenses out there, but with the sclerals and the mini sclerals that are out there, I'd probably do more sclerals now. If those weren't available, that's about the time right before sclerals became popular again, that I was going into the kind of that piggyback type of procedure. And for those that are out there, you take a soft lens, put a rigid, fit that first, and then that helps kind of remold the cornea. Then you can put an RGP on top of that. It's out there. Anything rolling in, Joe, before I move on?
No, a couple of people responded to Susan. Jean says yes. Robert says no, since he discovered scleral. Amy, the patient sedated during cross-linking, very, very, very mildly. Very,
Yeah, I would say
very
I would
mild.
say at most maybe Xanax. I mean, I've
Yeah.
sent these patients down. They numb the cornea. Maybe if they're claustrophobic-ish, maybe they would resort to maybe a Xanax type of thing. But that would probably be the answer. They're not put out. They don't use Versed like they do for cataract surgery. It's kind of more of an in-office procedure type of thing.
Indeed. Mhm. We're good.
Good. All right. Let's move on. 28-year-old man had LASIK. Oh, we're still in that cornea. So let's blow through this one. I'll go through this one pretty quickly so we can get into some new subjects here. We have LASIK 14 months ago. Right eye is now very blurry. Try to call. The center's closed. You can see right here, 20/40 with 7 diopters of astigmatism. Everything looked pretty good. Few multi-directional striae, the interface was clean, nothing really big, but what I wanted to show you is what the topography looked like. You can see the topography was very steep here in that posterior float. Not that keratoconus type of procedure where maybe it's more inferior or pellucid, kind of more central. And basically, you can see here 375 instead of 379. Again, it's really not the number, it's just you can tell things are thin here. He's bulging. And this is just a case of keratoectasia for this patient. He had LASIK and ended up with keratoectasia secondary to LASIK. Now, this is I'll give you the abbreviated version of this case. You can see this is a pretty older case. He finally had a PKP in 2006 to this right eye. He did really well in the left eye. As you can see here, he was 2020 with minus a quarter. Well, then like 2012-ish, 2014-ish, things started to change pretty rapidly. Didn't have access to cornea cross-linking. Actually sent them someone doing off-label cornea cross-linking, said, hey, I don't really want to touch this. And basically, I don't know, 2018 ended up with a now bilateral cornea transplant. This patient, the summary is he's one of those guys, hey, I was the one that was, I guess, being a little bit aggressive. I guess I should have just been happy with my contact lenses. Things happened to me. He ended up with bilateral cornea transplants. He wears RGPs. He's 2020. He's not he's not suing people, this and that. He's just kind of like, hey, I was the one that made the decision, and that's where he ended up. But I just kind of wanted to show you what the topography looks like going back to that posterior float. All right, let's open up this question here. And it is, recurrent corneal erosion is a disease of the tear layer, the anterior basement membrane, elastin collagen of the stroma. Never thought of it this way. So recurrent corneal erosion. Oop. Is that still open out there? I bumped the close by accident, but I reopened it. Let's see if we get, yeah, the responses are rolling in. All right.
People are moving.
Yep.
And the chat is clear. People are just talking amongst themselves with their experience on scleros and piggyback lenses.
Sweet. Yeah, I have a doc in the area. He does them. He does them successful. All right, I think we've kind of got the trend going here. I'll do the display. I think everyone's pretty much on top of it. Anterior basement membrane. A few people saying elastin collagen, and someone just saying, hey, never thought of it this way. So good. All right, so close that and let's move on. So this is a 43-year-old man called the office today. He's got pain in his right eye. Happened this morning. He's 20/80. Externals are normal. Review of systems, everything's unremarkable. Comes in, we put the sodium fluorescein. And remember, sodium fluorescein doesn't really stain. We call it a stain. It actually pulls. It's a water-loving dye where that pothole is thick and that water fills in, like down here with the tear prism. It's not really staining the tears. It's just water-loving. And when you hit it with cobalt blue light or a Ratten filter, it just kind of lights up greener. It's just thicker in that area. So you can see we have a corneal abrasion, corneal ulcer, herpetic lesion going on here. Looked at the other eye, and in that same area, we got this kind of EBMD, these little putty gray little areas, things. You narrow down an optic section. We're at that basement membrane. So he has EBMD bilateral. Talked to him. This is the 4th time in the last 24 months. He's using Muro 128 drops. So now we got a new diagnosis. He's got recurrent corneal erosion secondary to epithelial basement membrane dystrophy. And what I like to do when these patients come in, if I'm not sure, just jump over to the other eye, EBMD, bilateral, typically asymmetric, but bilateral. And this can kind of help out. And the history tells you, the 4th time in 2 years, and he's using Muro 128. Now, this is pretty straightforward, right? We all know how to treat an abrasion. The key is, what are we going to do once we fix that abrasion that's out there? So what we're looking at here is, we have antibiotic, pain management. You can go with a bandage contact lens. You can do ibuprofen, acetaminophen. You can do opioids. You can use some topical NSAIDs. I wouldn't do that because it numbs the eye, but throwing it there onto the list. We all know how to treat a corneal abrasion. Here's our review of map.fingerprint with EBMD. So now this is where the fun comes in. What are you going to do when you get this thing healed up again? It might take 7 days, 2 weeks. You got this eye healed up. The abrasion certainly doesn't want it to happen the 5th time or the 6th time, within the next year. So what are our options? Medically, you can see someone's already using hypertonics. I'd like to get Joe's opinion. I've really never had success. It's nice to talk about them. And then, Joe, I always say this because you're usually doing another lecture. You're usually doing one of the Florida required courses. I'm going to have you help me maybe write this up. You're definitely more of a gifted writer than I am. We have bandage contact lens. I probably have right now, because one passed away recently, not because of my nocturnal bandage contact lens, just due to age. They tear open in the morning. So they don't really want to go for PRK, the doxycycline. Nah, I don't want to be on an antibiotic. Don't want to do an amniotic membrane. So I say, look, you tear open in the morning. So I put a focus night and day in, minus a quarter, plus a quarter, whatever that we want to use. Basically like a retainer that someone uses for at night for when they have like braces, and they wear a retainer, put the retainer in at night. I have them wear it, sleep in it, get up in the morning, kind of maybe start their day, and then remove the lens. And that works really well for some of these patients. I've had some doing it for 2 or 3 years. We stopped one recently, tore open, and said, looks like we got to keep it going. So wearing a bandage contact lens nocturnally. Doxycycline, minocycline is a medical treatment. Amniotic membranes, we're going to talk about that here in a second, something like Procara. You could move on to surgical procedures like anterior stromal micropuncture, or you can do debridement. That could be chemical or mechanical. And if I can't get an amniotic membrane and doxycycline to work, maybe they want to go to nocturnal. I really don't go into the micropuncture, debridement. I just refer to my corneal specialist, where they typically do PTK, phototherapeutic, which is basically PRK, maybe a little bit of prescription. And how that came about was back in the day when PRK was there before LASIK, and they would remove the epithelium. What they found out is whenever they went back to do an enhancement, it was always harder to get that epithelium off, right? And that's when maybe the alcohol came into play, putting on the epithelium, softening up and removing it, so on and so forth. But it was hard to get that off. So they said, what if we can just use the excimer laser to kind of tighten that up? So that's a treatment that's out there. Now, when is it time to go to a surgical procedure? And this really goes like glaucoma, cataract surgery, maybe retina surgery, really any surgeries out there. And this might help you out if you send someone for an SLT. Maybe it doesn't happen as much anymore since SLTs are becoming first line. But you'd say, let me send you for an SLT. And the surgeon would say, surgeon would say, let me put you on a second med or a third med. It would drive you crazy. Like, wait, I could have done that. And it's because they're trained to make sure you exhaust all medical options. So when I make referrals, what I try to do is I try to go through and say, okay, did I really exhaust all medical options as I make this referral? Did I try my hypertonics or my bandage contact lens? Patient refused, amniotic membranes, whatever. Make it clear in the record, and that's why we're sending them for a surgical treatment. So when you exhaust all medical, that's when it's time. So back in the day, before cataract surgery became as kind of refractive surgery now, some of the surgeons would be like, let's just try this, -1 and -4. We knew the anisometropia, but they wanted to make sure they exhausted all the all the medical treatments first before doing surgical. All right. So let's talk about PRK. Let's talk about amniotic membranes. So amniotic membranes, I've had a ton of success with amniotic membranes. I always say I'm going to jinx myself because I'm like 20 in a row now with these amniotic membranes and treating recurrent corneal erosion that's out there. Just a real quick talk on amniotic membranes. Remember, this is more kind of functional medicine. This really isn't opposites curing. We're taking something that's biological right here, the placenta from a baby, and these companies, they don't really like hang out the hospital and says, hey, look like you're gonna have a baby today. I'll give you $50 for that placenta. This is all planned. This is all well organized, orchestrated out. Things are checked, blood work, and these are planned C-sections where these amniotic membranes come from, and the placenta. So of the placenta, it's the amnion that is then eventually turned into these discs that we can place on the patient's eye. Now, I like Procara over the literature that I've read over the years. It seems more the biologics are preserved in this kind of cryo-preserved process. For recurrent corneal erosion, like I do dehydrated for dry eyes and things like that, but this is a more kind of aggressive. I want to try and get some more biologics that's out there onto the eye. And remember, amniotic membranes, they're great for anti-inflammatory, anti-scarring, anti-angiogenic, promoting stem cell expansion, promoting cellular migration. And the nice thing about it is it does have pain suppression, which I remember back, probably now 15 years ago, where I was doing my first recurrent corneal erosion. I'm going to save that to show you what kind of happened to me whenever I did my first recurrent corneal erosion, removing that epithelium. I have a good video coming up here. So we can use it as a biological cornea band-aid. Now, Procaras you can call that with, I have a whole other lecture for amniotic membranes, dehydrated or more wound covering, as opposed to wound healing when you come to a Procara. So, there's the slim, there's the plus. I would probably use a Procara slim on these patients. It's basically single layer. The other thing is this polycarbonate ring, and then the Procara Plus is double. I usually use those for my infectious keratitis or maybe my corneal chemical burns that are more in that basic, and I want to really get that cornea as protected as possible. So don't forget about amniotic membranes that are out there. You can add a little doxycycline. The doxycycline inhibits that MMP9, which helps with that. It's a breaks down, and it's been found in higher levels with patients with recurrent corneal erosion. So 50 milligrams twice a day, amniotic membrane, maybe doxy for a month, the amniotic membrane till it kind of wears away. And a calm eye usually is about a week, maybe a little bit less, and then you could take that ring out. Now, we have exhausted all the medical treatments. You can refer to a surgical treatment. And PTK is good for corneal opacities. So we got scarring and granular dystrophy, Salzmann, and then that breakdown, which we're talking about here with this patient, EBMD, where you're going to, it's basically PRK, manually remove, and polish with an excimer laser. Now, what I want to show you here is a video of a PRK procedure. And the PRK, I'm going to just play it here. Well, let me pause it. You're going to see that the patient's going to come in. It's an older procedure, very old PRK. So they're not really even using any alcohol to soften that cornea. So, but I want to point out, and I'm glad they didn't here, and it's an old video, because I want to show you how much they scrape and watch this cornea indent, how much scraping they do. Watch this here. All right, here we go. We get started. And watch how, look at that cornea indenting. Look at all the scraping going on. Look at how aggressive I want to point out. Because the next video I want to show you, watch what happens with like an EBMD. Look at that cornea. Look at all the scraping going on here. Scraping away. And again, it's an older PRK procedure. They don't do it really like this anymore. They soften that epithelium up. All right, got the point. Now, let me show you a PTK. Now, this was a patient before I started doing the amniotic membranes, and my surgeon sent me this video because you can see the eye's red, it's inflamed. You can see even on the day that they show up that they have, an abrasion going on here. But watch how easy, this is the EBMD part. This is that dystrophy part, that Velcro, how diseased it really is. Watch this. Here's that same kind of spatula. And look, it's just how easy, softly coming off. So imagine now that patient going to sleep at night, eye dries out, the eyelid sticks down. I don't know if it's REM sleep or whatever, when that eye shakes or whatever, that it tears it open. But that's why, 4 o'clock in the morning, I woke up and felt this, pain in my eye, and now my eye hurts, and they come in the morning. But look at that epithelium, how easy that comes off. That is the best or the worst, whichever way you want to classify it, epithelial basement membrane dystrophy. Now, I don't know, 15 years ago, whenever I started doing amniotic membranes for these, I remember saying, okay, I'm going to take off some of this loose epithelium. I just had a Wexel sponge, numb the patient's eye up. I'm behind the microscope, and literally the same thing is just happening here with a Wexel sponge. And that's whenever I found out the power of an amniotic membrane. I used ProCare for it, and the pain suppression, because the whole cornea came off. We know how it is whenever the patient gets a small abrasion. I'm like, geez, oh man. Because typically I put them on and I say, I'll come back in 4 or 5, 6 days, depending what day of the week it is, seeing if the membrane's still intact. I'm like, you need to come back tomorrow. Why don't you take some Tylenol, take some Advil? I'm like, geez, am I going to need to do Lortab for this person? Tramadol? What am I going to need to do? And luckily my technicians go in first. I said, Sarah, well, hey, what's going on here with the patient? She's like, hey, listen, because she was in the room watching me debride this. And she's like, listen, she says the eye feels good. So that's whenever I found out the power and pain suppression of these amniotic membranes in these biologics. So you can see
Hey,
here,
Greg,
this is, yes.
something came in about the amniotic membranes. Good question. I think we can do some clarification. It's being asked, how often are the membranes replaced? Really, not really replacing them. You're letting them dissolve. But if there's a ring or a contact lens involved, we've got to take that off. Why don't you share your thoughts on that, Greg?
Yeah, it's a great question. And Joe, you're exactly right. The dehydrateds really don't have rings. They just placed on the eye. Here's the best clinical pearl I can give you. The hotter the eye, the quicker they'll dissolve, right? So the ProCare I like because it is a ring. The representative will always come in and be like, oh my gosh, the pain and misery that you're putting these patients through. Well, not really. They're usually coming in with a recurrent corneal erosion, some type of keratitis, maybe some type of infection. They're usually their eyes pretty hurting. I need to go with something that can heal it. So, and this clinical pearl goes for dehydrated and cryopreserved. Just one has a ring, one doesn't. When you put it on the eye, the hotter the eye, the quicker it will melt. So if you have a pretty hot eye, like an infectious keratitis, that's why I go with the double membrane. Because if you put a single membrane on and that eye is hot, I bet you would burn through that membrane in 2 to 3 days. When you do a dry eye patient and their eye's not real hot, it could last, 7 days. I think the longest I ever had one last was kind of 10 days. Now I'm going to feed off of a question here. What is the amount of days you really want to have it on there? So I usually get that question when I do this live. So I tell people, think of it as bubble gum. You put bubble gum in your mouth, it's got great flavor. Sometimes I'll forget about it. I'm going throughout the day, didn't get to eat that day. And 3 o'clock, I'm still chewing that piece of gum that I put in at 9 o'clock. Yeah, I can tell that it's spearmint, but it doesn't have a lot of that flavor when I put it in at 9. And so biologics that's what we're using in these amniotic membranes to heal these eyes. We want to have them on there about 3 days. At about 5 days is about max. That 6th day, you're getting kind of that bubble gum. You can tell that there's a membrane there. It's that 3 to 5 day period. 5 days, from what I have read, is right where you want to be. 3 is good. 5 is the best. You start losing the return at about 6 days. But the hotter the eye, they burn through. So that's why I like using that double membrane on those really hot eyes. Any other questions?
We're good.
Anything you want to add?
Are we done with RCE?
Yeah, let me just do this real quick. This is a patient with granular that we did a PTK procedure on and cleared them up. Here's a Salzmann nodule. What they did is they removed the Salzmann nodule and cleared it up with the PTK. There's what it looks like with the placido disc. That's a placido disc from the orb scan. I just kind of snuck in there with my phone and took that picture, and it came out really, really nice afterwards. So that's really the end of that, recurrent corneal erosion. So whatever pearls you want to add on, please do.
I have just a quick diagnostic pearl because we have all learned in second grade of optometry school that we think when they open their eye, they have pain or they pain when they wake up. It's recurrent corneal erosion. Okay, I've seen many examples, and one malpractice case where I'm defending. Here's where things go awry. You have to ask the patient, did you open your eye and then had intense pain, or did pain wake you up? So did you wake up with pain, or did pain wake you up? If you wake up with pain, that could be recurrent corneal erosion. It's sudden. If the pain wakes them up, it's a corneal infection. Their eyes are closed, nice and warm, lids are not shearing off bacteria, they're proliferating, gets painful, it wakes them up. That's not recurrent corneal erosion. Case I'm defending, there's a question as to whether or not they misread a corneal infection as recurrent corneal erosion. Now, a couple questions came in. So this is clarification. Will the epithelium, when the amniotic membrane dissolves, does the epithelium grow back normally?
Depends on what case we're talking about here. We're talking about, in this case, a recurrent corneal erosion. We can actually, in recurrent corneal erosion, use a bandage contact lens, pressure patch, whatever you want to do. You can get that epithelium to heal. What we're doing with the recurrent corneal erosion is kind of helping that epithelial basement membrane kind of come back to life or kind of stick down again. If you're talking about like an infectious keratitis, yeah, the epithelium is going to close over. It's just whether or not whatever cornea condition you're using to treat this with is going to create maybe a scar. I use these a lot in my central herpetic lesions. Dead on. I just had one the other day. Dead on central herpetic lesion. Put them on 1,000 milligrams of Eltrex 3 times a day and put a Procara on that, just trying to minimize the scarring. I mean, it could not have been placed any more perfectly centered over that pupil. So I guess the answer would be the epithelium is going to grow back. Yes, normal. It's just what condition that we're using it for, whether you end up with a scar or some type of corneal, maybe irregular stigmatism or scarring. Anything else? We good? All good on questions, Joe?
We're all good.
All right, perfect. All right, so let's do number 6 here. This is an 84-year-old woman, right eye red and painful, started 10 days ago. Let's see the photo. And so here we are, kind of zoomed in. Here we are zoomed out. Obviously here's the nose, upper eyelid. We've got this kind of cellulitis going on. She doesn't have a fever, so it's like a preseptal cellulitis. You can see here we have a big old infection, and she has a dacryocystitis. So this is where now our orals come in. You can see here that the eye's pretty quiet. She really didn't wake up stuck shut in the morning. So this is more orals focused for the infection that's out there. She does have tearing though. None of the tears can drain out, so she's got a lot of epiphora. I think maybe she had a little angular conjunctivitis in here from all the wetness and the irritation, but you can see this is an infectious process here. So, we treated the patient, for this. We put her on a topical, you check allergies. We won't do the oral antibiotic, but I would typically go with Augmentin in this case if they're allergic to penicillin, maybe a Z-Pack if they're allergic to penicillin. You can go Keflex, you can go further down the line to Bactrim or maybe avoid your fluoroquinolones in an elderly patient, but not penicillin allergy. I would do 500 milligrams of Augmentin twice a day. Put this patient maybe on some polytrim to cover a secondary infection. You can see this is what she originally looked like. And you can see about a week later, she's responding well. You can see the infection that was in the skin, the cellulitis, the dacryocystitis is improving, but she's got epiphora. So I'm going to get a DCR consult on this. I pretty much figured that her sac with that amount of infection was probably blown or broken. So we got a DCR. So a DCR, this is an okay cartoon. Basically what they do is, here's the puncta, you have the cannula, the common cannuliculus, you got the nasolacrimal sac, you got the duct, and there's a blockage here. So typically what the surgeon will do is find out where that blockage is, and then they cut right above where the blockage is. All right, well, now you don't have anything draining into the nose. So what the surgeon does is a little bit of, reconstruction. They literally, if you ever watch DCR surgery, they go in, cut through the skin, find out where that blockage is, cut above it, set that off to the side, kind of break around that nasal lacrimal fossa, and literally punch a new, like with a, I don't know, like a hole punch right into the nose, through the bone, kind of crunch, 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 open up a hole. Now you pull the nasal mucosa through, and then you sew the bottom of this tube right here, the nasal lacrimal duct, into the mucosa of the nose. Now that's a lot of trauma. The reason why I don't like the cartoon is this is pretty high up here. But what they'll do is they'll go through, that's a lot of trauma. So you got to put the silicone tube in. So you put a tube up through, down through, comes out the nose, through the lower puncta, through the common cannuliculus, through that duct where the new opening is, down through the nose, tie a knot, tie a knot. And the reason that you do that is as all that trauma that you just created, punching through the nose, pulling nasal mucosa, you don't want that to grow shut, right? So you put a silicone tube in here. So here's our patient. Here's our patient. There's an external way of doing it. And sometimes, they'll say, look, you can do external, but if you don't want to have a scar, but look how she's like, look, I got enough wrinkles. I don't have to worry about a scar, but look how nice that wound. It took the stitches out for her. But you can see the tube is in place right here, and it's going through. And you can see how well she healed up. And there's a knot somewhere in her nose here. They don't get epiphora because that tube acts like a candle wick and pulls the tears down. Now, the surgeon that I use for these, he'll tell me to leave it in there 6 months, 8 months, so on and so forth. And then I'll take them out because I have to send these down to Pittsburgh. But basically, that's a DCR. I just showed you that's the external. There is an internal where they'll do an endoscopic DCR. When you look at the literature, little higher success rate external. So that's why I'll say to the surgeon, or I'll say to the patient, look, you have a blockage. You're probably going to need DCR external. I send them to my oculoplastics. If they want to go endoscopic, I send them to the ENT doc. So it all depends which way they want to go, where they want to have a little bit less success, but maybe not a scar on the outside or a cut on the outside, or if they can go to my oculoplastics for there. So here's what she looked like before, and we did a good job with her, with co-manager, with the oculoplastics and getting that fixed. Now here's a tube removal. Sometimes I can see the knot, and if the knot's not real big, I'll do this type of procedure. All you have to do is cut that, and sometimes just have them blow their nose, or if they want, they can pick their nose and they can just pull it out. This knot went really up high, and so what I did is I removed it this way. So you're going to see here, I'm just going to reach in, grab that, pull it a little bit. Now remember, it's tied, so you can't pull on it. You got to cut it. So I'm going to cut this right here. I'm just going to grab that lower lid and just kind of feel it, and boink, there comes the knot, and now it's out. So this was about 6 weeks after the procedure. And the medical legal term for this right here is a booger. So that's just a boogie that's on
Alright.
that. So
Okay.
that's it. Just a real showing you just a tube removal. All right. Any questions come in, Joe?
We're good.
Okay. All right. Let's do a polling question. Is this a CRVO? Is this a central retinal vein occlusion? Yes or no? Is this a central retinal vein occlusion?
People jumping on it.
Okay, people are responding quickly. Thanks for being synchronous, virtual here and replying. So, all right, I'm just going to display it real quick. I think we've got the trend in. We have 40%, 41% saying yes, and we've got 60% saying no. All right, I'm going to close the question, close the display, and let's jump in. So, this is a 35-year-old man. You're going to get the answer here shortly. So here's a 35-year-old man wants another opinion for the hemorrhage that's on his right eye. It happened 3 days ago after vomiting. He claims he ate some chicken Caesar salad, felt a little nauseated, got sick. He saw the ophthalmologist 3 days ago. Was told he had a bruise on his eye, and it would go away in 1 to 2 weeks. So he's coming in for another opinion. So I walk in after he's all worked up, and his best corrected acuity is 2100 in his right eye, the eye that has this hemorrhage. He's 20/70. You can see he's got a history of amblyopia in this eye that has the hemorrhage, and he's a +5 and a +450. So what's the concern here? Any concern? And I like to do this with a live audience, but I'll let you think about it for a second, looking at this data. And when I walked in, everything's about his right eye, but why is he best corrected to 20/70 in this left eye? So I asked him that. And he said, okay, I noticed my vision getting blurry in my left eye. I started about 2 weeks ago. I didn't mention it because, hey, doc, do you see the blood over here in my right eye? And I said, yeah, okay. And so we had this kind of tennis match back and forth. I see his right eye. I'm talking about his left eye. So we decide to, dilate him. While we're talking, we find out that he has headaches, and they decrease when they stand up. And, when you change that posture and those headaches start to get better or worse, that's usually not a good sign. There's probably something maybe going on intracranially. Just keep that in mind as, go see patients. So he's 35 years old. Everything's unremarkable. He's literally in town from Atlanta, Georgia, to help his mom go through a colon resection. So he just happens to be here from out of town. He's got this going on. Noticed it 2 weeks ago. We decided to dilate him. And now this is what we have. So I showed you this picture before, and 56% said, no, it's not a vein occlusion. And now we have this in the other eye. So I remember this, case, clear as day. I remember looking in the back, with an undilated 90. I'm going to dilate you. And I say to my photographer, I say, hey, listen, look, you got to have the poker face, because she's really good. She'll come in, retinal detachment, this and that. I said, look, there's blood everywhere on both eyes. I said, take the pictures, and just say, oh, Dr. Caldwell's going to take a look at them. So luckily we have these external viewing stations. So it wasn't until I looked at them external, was kind of studying them, that it started to come to me what was happening here. Because I felt it first. That's where the question came from. This person has a bilateral central retinal vein occlusion, 35 years old. Now I'm trying to do the differential. Are they going to the ER? What do we do? And so on and so forth. But then I said, it's not a central retinal vein occlusion. And the reason being, there's blood at 3 levels here. You can see that there's kind of this boat-shaped hemorrhage here. That is, where is that? In front of the internal limiting membrane, hasn't really busted into the vitreous. So it's between, the posterior vitreous face, it's pre-retinal in front of the retina. Now, this blood here is under the neurosensory retina, right? It's above the RPE, but not below the RPE, but not in that vitreal space. And then you can kind of see that this is elevated, and maybe there's some blood in this area here that is subretinal. You can see it over here better. This eye is a lot easier to see. This is the one that quickly, because this is elevated. You can't really see the blood because it's under the RPE. So we got RPE blood. We've got right here, we've got blood under the neurosensory retina above the RPE. And this is a pre-retinal hemorrhage right here. So now I'm going, I remember in my residency, like macular degeneration, it will bleed to 2 levels, under the RPE and above the RPE, but really doesn't bust through the neurosensory retina. Diabetic retinopathy with neovascularization of that surface of the retina. Yeah, you can get maybe some subretinal blood or some vitreal blood. 2 areas, 3 areas, it's got to be coming somewhere. And I remember, in residency, and I had to go pull the Anoff book up, and I remembered it, and I found it, Terson syndrome. And what's happening is there's blood inside the brain, and it's coming down the optic nerve head sheaths. And as that optic nerve head plugs in to the retina, there's a loose association. So some is going under the RPE, some is going in front of the RPE, and then some is going, because he's got that young vitreal hyaloid face, it's not busting through the vitreous, but it's going in front of the vitreous or going behind the vitreous in front of the retina, that internal limiting membrane, 3 areas. And this was the photo that did it, because I could see 1, 2, 3 layers of blood. And it's a little bit harder to see over here, but here's one for sure, that pre-retinal or pre-retinal, subretinal here, and then sub-RPE, sub-RPE. So hypertensive retinopathy, blood dyscrasia, turns out to be a Terson syndrome that's out there. So now what's Terson syndrome? Terson syndrome was originally defined by the occurrence of vitreal hemorrhage in association with subarachnoid hemorrhage. Terson syndrome now encompasses any intraocular hemorrhage associated with intracranial hemorrhage and elevated intracranial pressure. That's where the headaches were coming from. It could be intraocular hemorrhage, which includes subretinal, retinal, subhyaloidal, and vitreal blood. In this case, it didn't bust through that vitreous because he's 35 years old. So we sent them, I sent them to the emergency room, because I said, look, here's what's happening. You got blood coming down, you got these headaches, it changes when you change your posture. So let's get you to the emergency room. So this is back in the day, literally faxing, so on and so forth. So I copied the Yanoff book, the pages on Terson, sent it over to the ER, said, look, I have a patient coming over. Can I speak to the neurologist on call? One of them, the neurologist on call, that I dilated, the pupils aren't blown. And I said, I think we got a Terson syndrome here. And long story short, what happens is he ends up having that intracranial hemorrhage confirmed with CT or MRI, I think CT first, then MRI. And then he had some blood work, and he ended up having hairy cell leukemia and cryptococcal meningitis. Now, this is a good story. He goes back. So I guess if you're going to get leukemia, I'm not a leukemia expert, but that's one of the ones you want, because I guess it's treatable, that's out there. Because he went back to Atlanta. He was able to get treated. They cleared up the cryptococcal meningitis. They cleared up the leukemia. I don't have any follow-up photos, but I do know from the doctor that he saw that he did get back to 2025 in that left eye. And still to this day, I get a Christmas card from him. So I know that he's alive and doing well. So pretty cool, fun case here of a Terson syndrome. I have had, probably not to this extent, and I was looking for the photos today because I have them in other lectures, and I didn't get them added, but I probably have 3 cases not to this extent that's out there. So that's a Terson syndrome. The key is blood in 3 areas. That's the clinical pearl that I want to drive home. Joe, any questions or any questions out there or any comments?
No, nothing came in from the audience, but if you can go back to the bilateral photograph. I'll just throw a couple
Absolutely.
of real quick clinical pearls. And maybe in the future, because you had a really good picture of a CRVO in the first case. Now, the question is this a bilateral CRVO? And the reason I say no is because it's going the wrong direction. CRVO is a venous outflow disease. Now, these aren't wide field, but I can see there's a lot of clear fundus out here, and probably all the way around there, it was probably clear fundus. So that would be involved in a CRVO because it's all coming in and going out that way. Now this is coming toward you. This is coming out. So bilateral coming toward you, you know it's intracranial. So all that blood is being transmitted along that common optic nerve subarachnoid sheath. Now, where does these usually happen? Head trauma. Fell off a horse, motorcycle, some sort of accident, slip and fall. That's what you got to consider. Now, if they don't have a history of slip and fall, you think headache because they have now a leaking AV malformation or an aneurysm that's leaked. That's all. So this is really going the wrong direction. It's coming out toward you, not blood going away from the peripheral retina down the optic nerve.
Yeah, that's a good point. Yeah, that'd be nice. I'll put the think when I do update these slides, I'll just put that picture of a CRVO right there.
Yep.
Good pearls. Yep. All right. Okay. Anything in the chat box?
Nothing. We're good.
Okay. 58-year-old woman. Let's see how we doing with time here. We'll make sure we get to a couple of these. Yeah, we're good. All right. 58-year-old woman, 2200, 2400 with a long-standing history of macular degeneration. What is suspicious here? Just ask yourself. You don't have to put it in the chat box or anything. What is suspicious here? So how can a 58-year-old have a long-standing history of macular degeneration? So let's take a look. So she has a history of cataract surgery. She's a -1 with her glasses. All right, here are her retinas. All right. So what's going on here? So we can see here that here's an optic nerve, here's some blood vessels, here's some sclera, and a little bit of a hint here. Axial length is 29.85. 23.5 is normal, and she was a -18 prior to cataract surgery. So what we have here is a patient with degenerative myopia. So I got a question here I want to throw to the audience, and I just opened up the polling questions. Let's go to polling question number 5. Is what diopter value do you consider someone a degenerative or pathological myopia? -5, -10, -12. Hey, you're trying to trick me. Which one is it? What diopter value do you consider someone a degenerative myopia? I got another question here. It's not on here. Just, do you like the polling questions during the webinar? So do you like the polling questions during the webinar? What diopter value? 5, 10, 12. Hey, you're trying to trick me here. All right, looks like we've got a good response here. So let me display, and this is fun. This helps me out when I do the live. So thanks for everyone for showing up here. And I'm going to display the results. And we have -5, 16%. We have -10 at 28. 24 is saying, so we like that 10 response if we're going to use the phoropter. And we got 32% saying, hey, you're trying to trick me. And that's exactly what I'm trying to do, right? So trying to trick you here. I'm going to close that question. And we have majority, 96% that like the polling questions. We have 2 people that don't, but we have to do it to make it synchronous and be really code compliant and CE broker compliant. So thank you. I was hoping that you were liking the questions. All right. So it's not diagnosed by the phoropter. And the reason being, I have this happen like twice a year. Once every 6 months, I walk in the room. Hey, I'm Greg. How you doing? Hey, I'm so-and-so. I'm doing well. Can you tell me when I'm going to go blind? And I'm like, whoa, 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 whoa. I just walked in. I just met you. I didn't give you any diagnosis yet. And they're like, yeah, like I'm a -12 and my doc says I'm a progressive myopia. So I got on Google and I was reading about progressive myopia or pathological myopia, degenerative myopia. And I don't, hear that it's, over time I can go blind, right? This is the myopia control. This is the big pandemic that's out there. I hate using that word with the COVID, but that's what you're seeing in like the Asian countries. I've been to Singapore plenty of times to lecture, catching on in Europe. Degenerative myopia, pathological myopia is kind of keratoconus of the back of the eye. You got a posterior staphyloma of the macula that stretches. And yes, this is a degeneration of the macula. It's not macular degeneration, but it's a different animal than axial, just regular old myopia. You have a disease of the elastin and collagen creating that posterior staphyloma. Keratoconus of the back of the eye is what I consider degenerative myopia. And it's a condition that is not diagnosed with the phoropter. Okay, so yes, tricky because you can have a -10 that's a pathological myopia and a -10 that's an axial length. So it differs from refractive myopia and the alterations of the globe that is progressive. So it has a posterior staphyloma. Now, here's the findings of degenerative myopia, but they also have scleral crescents, vessel straightening, and tilting. This can be found in refractive myopes also. But that fuchs spot, staphyloma, lacquer cracks, those are degenerative myopia. It's a disease of the macula, of the posterior pole. So with that being said, it's been associated with these conditions. And there's really not much I could do with this patient other than give them some assurance of what's going on. They don't have macular degeneration, which is different because we know that kids, could be in the family and they might be worried about macular degeneration, and we're going to monitor them for neovascularization. So because of the time, I'm not going to run the polling question here, but I'm going to just ask it. Which patient is at higher risk for a retinal detachment? Ask yourself. The 8 diopter myope, axial myope that we see all day long, or that 14 diopter? I'm going to lie. I'd like to see the answers to this. I'm going to scroll down. I'm going to open this question up. Maybe I'll go through. I'd like to see the answers to this. Which patient is at higher risk for a retinal detachment? Is it the 8 diopter axial myope, or is it the 14 diopter?
You're caught up on the questions, Greg, and as it's rolling in, I just wanted to remind you, I know you have a public service announcement you wanted to make.
Yep, I'm going to do the last 2 cases in 8 minutes here, 8 to 9 minutes, and get them done here. So, all right, let's just post this because it looks like the polling is in. This is why I like to do the polling questions, because I like to, whenever I do the live, I can say, this is what I see also happen. So here it is. We have about a 76 say that it's the -8, and we have 25%, 26% saying. So the audience is correct. Where I'm going with this is the -14 is at less risk. And I did this in front of a retina group the one time, and they were about 4 retinologists sitting back, and they raised their hand and they said, you know what, doc, we never thought of it this way, but it's true. We do more retinal detachments on axial myopes than degenerative myopes. And the reason being, what I want to point out is, if this is the normal curvature in a refractive or an axial myope, the periphery becomes more of the issue. In a degenerative myope, what I'm trying to show here is this curve kind of matches this curve. The stress is not here. It's more of a posterior pole versus peripheral. And that's why the axial ends up with more retinal detachment. So I like to think of refractive or axial as peripheral retinal changes, and posterior as macular changes, that pathological myope. So we have the peripheral findings would be paving stones, which don't really increase risk, but lattice degeneration, depending on where it's located, can increase risk, more of a peripheral fundus change. All right, let's get to the public service announcement. Let's do polling question real quick, and I'll run through these cases pretty fast. I'm curious, has anyone had a patient with ovarian cancer and have been using Elahere where you had to clear them for this medication? Every time I do it live, there is someone that has had a patient. So we have this great discussion that's out there. So let's do this real quick and display. And we have one in here so far. So perfect. All right. There's always one that's out there. So good. The other the other attendees have not. So let's do this. This is that public service announcement that I want to do. Elahere, I did sit on a committee on this about a year and a half ago, and this was dear to my heart. Elahere is a biological medication that has to it this thing that's called an antibody drug conjugate. So it's a biologic that uses the binding procedure of a biologic, but it's got the payload that can kill the ovarian cancer. And this is important because this is kind of like a last ditch effort. My clinical pearl is make sure you notify your staff that if anyone calls with Elahere, that you'll get them in that day or the next day. You don't want to be like, hey, I'm 6 weeks busy. I'll do that 6 weeks from now. That's not what you want. The oncologist is not going to wait that long anyway. And the other clinical pearl is reach out to your oncologist. I reached out to my oncologist and said, look, I'd be more than happy to see these patients, okay? Because it has a black box warning of a keratopathy. Now, I'm going to go through this pretty quick here. So the key is these patients need to be cleared. Here's the Elahere. Here is the cancer cell. It's using the biologics. Biologics typically use receptors. Here's the medication. It recognizes it. It brings it into the cancer cell and then kills the cancer cell. You can see here that the cancer cells are dying. It's for these patients that have this FR receptor, alpha positive platinum resistance ovarian cancer that's out there. So the point is, be aware that this medication is out there. They can't really start it until they get clearance, and then they need to be followed up. And it's a very specific type of follow-up. So here's the black box warning that's out there. You can see dry eye, photophobia, so on and so forth. And we have the mechanism of action here. If you want to read through it, it's in all the slides. You can read through the pathophysiology of how this keratitis kind of builds up. I think amiodarone keratitis is probably worse. This is a last-ditch effort. They come in already on steroids and lubricating drops. So you just want to be proactive about this. Reach out to your patient or reach out to your oncologist if you want to do that. And they'll already be on steroids. There's a specific protocol. All you're doing is doing a visual acuity, a slit lamp evaluation, checking the patient's symptoms, and reporting it back. Pretty straightforward. Here are some of those. Again, I think amiodarone keratopathy is worse. And the key is you don't want to delay it for the patient. Now, what I'm going to get to is this right here. If you want to scan this QR code, here is the ocular assessment. And you can see it's pretty straightforward. This will come over. They'll already be started on the steroids. They'll already be using the lubricant drops. You're doing an acuity. You're checking keratopathy. You're checking for a uveitis. Really straightforward. That's out there. So I encourage everyone to kind of take these notes, scan that QR code, and take a look at this. And the last case I want to do here is this patient here. I see these a lot, and my clinical pearl is ask the patients that come in with reduced vision, 2200 in their best seeing eye or 2100 in their better seeing eye. We see a lot of macular degeneration patients. Ask them if they are seeing objects. Like this 88-year-old man comes in and says, hey, I'm seeing faces of friends I've not seen for years in pine trees. And, went the wrong way. And so, would you recommend a site consult? I'm not going to run the polling question. This person is alert and oriented to person, place, and time. Look at the geographic atrophy right here. They're count fingers, right? But the rest of the retina is fine. What's happening is this patient is having a Charles-Bonnet syndrome. Charles-Bonnet syndrome is now also called a release hallucination. Now we see irritative hallucinations with migraine, the visual aura. What happens in a release hallucination, because our eyes cannot give, because of this right here, our maculas cannot give our occipital lobe, our images, the temporal lobe says, I got images that are here stored. I'll release them. So it releases these hallucinations. The low vision patients see it all the time. My clinical pearl is don't wait for the patient to bring it up. What I've learned is when I get to 2100 and they're better seeing eye, I'll just say, hey, Mary, hey, Joe, hey, Lori, are you seeing images? And all of a sudden they'll be like, oh my gosh, how did you know? And then they'll want to talk about it. And they want to make sure that they're not going crazy, right? So that's a Charles-Bonnet syndrome. What I want to show you is one of my best interviews of a Charles-Bonnet, and then we'll wrap it up here. Listen to this lady. Listen to how many times she says she's scared, how many times she's scared, and she wants to, not sure what to do.
All right, Lois, can you tell me what you're seeing? Go ahead and tell me again.
On many instances, when I'm reading in a recliner, I'll feel a presence, and I look, it's always on the right, and I look over like this, sort of like, what the heck's that? And there'll be people standing there, maybe 4 people that I don't know. Once or twice I did know the people, but mostly I don't know them. And they just stand there, and they just look at me. No expressions, they don't speak.
Notice how she says they don't speak. That's important. If they're speaking, that's different than Charles-Bonnet. They don't talk. They never speak, and these patients are usually scared.
Smile, they don't laugh. Neither do I, because I'm sort of scared.
Sure, to make it scary. Let me ask, you said that you've noticed people that you don't recognize, but the people that you do recognize, who were they that you recognized?
Like my daughter when she was 18, she's 52 now.
Okay.
Stored images.
And my other baby daughter, she was 8 then. And when I look over on my corner of my bed, she'll be sitting there like an Indian with her arms folded. And they just look at me. It's not exactly a hateful snare or stare, but it's...
but they're there.
They're there, and they're looking at me, and it makes me mad.
Do they go away at times? They're not there all the time, are they?
They fade away, yeah.
They fade away.
Now, my dad usually shows up in the dining room, at the dining room table. And he usually shows up when I'm carrying a tray of meat or chicken and dumplings into the dining room.
Mm-hmm.
And he's in his mining clothes. And he has his mining cap and the lights on.
Uh-huh.
And he twists his head around and the light flicks all over the room. And there I'm standing with the chicken and dumplings. I'm scared. I don't know whether to put it down and
They're
run.
scared, don't know whether to
Take
run,
it back to the kitchen.
but they never
Okay.
speak.
Or what to do.
Let me ask you one more. You mentioned about your granddaughter. Do you see your granddaughter?
So I'm going to shorten this up. She talks about her granddaughter. I said, is it her daughter? She said they're dresses that she made and so on and so forth. But I do want to show this video here real quick.
You know who the president is right now, right?
Yeah, Obama.
Do you know what year it is?
2016.
Do you know what month it is?
It's October.
You got it, kid.
Don't I come here October and April?
You do.
So she's alert. She's
that
alert
was
to
very good. Thank you.
pace, person, place, and time is what I wanted to show you there. So that's probably my best Charles-Bonnet. I got plenty of other videos that are out there of Charles-Bonnet, but we'll talk about another webinar about the clinical significance between geographic atrophy and a disciform scar. The last case is this lady here. We hit her really hard with all of this, and she ended up looking like Jennifer Aniston. So that was all the Xiidra back in the Xiidra day. So with that being said, we should have the little red dot popping up. So right here, there should be a little red dot if you want to take the survey. And Joe, are there any other questions that have rolled in?
One last question has rolled in that talking about cancer medication. Well, here, are the ocular adverse effects reversible if the med is stopped or changed?
The ocular events, the ocular side effects are reversible. However, they do use the ocular events to adjust the medication. And when they adjust the medication, most of the ocular side effects will dissipate or minimize. The other clinical pearl that I've learned from people that have done this, if you're going to call and talk to the oncologist, it can weigh on you because the patients come in, they have hope, they're going to have something, and you might watch the patient fail over time. I haven't had my first patient yet come in. I only do this from the audience when I do it live and I talk to them. And I probably talked to about 12 optometrists that have taken care of patients, but that's one clinical pearl. And the other one is, yes, they will fade over time. We good?
Someone just asked, can you put the QR code up real quick for the aileron?
Here's a quick review. There it is. And
I
it'll be in the
understand what you
handout.
say.
Go ahead, Joe.
I was going to say, I understand what you say because in my practice, when I was starting off, I was getting patients from the Florida Cancer Center for not this medicine, but other medicines. And you're right. You know, first visit, second visit, third visit, you can see a pretty significant change. And unfortunately, there's often not a fourth visit. I think we're good, Greg. Everybody's giving me a round of applause.
All right. So there's the QR code. You can always get it in the handout, download the handout, or you can email me. I'll be more than happy to send you the QR code, but that's the how to download that assessment form. So with that being said, I think all questions have been answered. That makes us COPE compliant. So thanks everyone for attending anterior segment and posterior case presentations. Enough pearls to make a necklace. This was a synchronous virtual course. Thank you for participating in the surveys. Joe, thanks for moderating with me tonight and helping out and putting in those excellent pearls of wisdom.